Welcome to another episode of the NEI podcast. I'm Dr. Sabrina Siegel, live at the NEI Congress 2019. It's day 2, and we are here with Dr. McIntyre for an extended Q&A session. Let's listen in as he addresses your unanswered questions from today's presentation.
Hello, I'm Roger McIntyre, Professor of Psychiatry and Pharmacology at the University of Toronto. In today's session, I covered the broad topic of the gut-brain axis with a particular focus on the microbiota, the organisms within our gut, and the implications that they have for both states of wellness and disease, with a particular focus on mental illness. And we said a lot about a lot of things. We had a lot of questions from colleagues, and I'm at this point going to use this time to go through some questions that came in from some of our colleagues. One of the first questions that comes in is there an optimal time for the gut biome with respect to duration of exercise? It's a great question. What we do know is that exercise does affect the gut biota. We don't know at this point, what's preferred in terms of aerobic or resistance. We know that both are good for mental and physical health. But with respect to specific effects on the biota signature, or for that matter, any specific effect on species or strains, that's not well known. But yes, we do now know that exercise may have, in fact, effects, and it does seem to have effects on the biota and on the biome. Another question came from one of our colleagues. Can I talk to the effect of smoking and the changes on the gut? What a wonderful question, given how common smoking is amongst people who have mental illness. In fact, we've seen rates of smoking decrease in the general population, but it has not decreased in people who have mental illness. People have looked at the effect of smoking on the microbiota, as well as they've conducted meta-analysis and reviews of this, and the literature indicates there's a decrease in what I call the R&D, the richness and the diversity of the microbiota in people who smoke cigarettes. And there's many theories that have been put forward to explain that. One of the theories, not the only one, is that smoking causes oxidative stress, and that could affect the actual biota. So perhaps some of the unhealthy outcomes associated with smoking in some people could be related to changes in the biota. With respect to another question, what are the manifestations of a hyperactive HPA axis, hypothalamic pituitary adrenal axis? During my presentation, what I had mentioned is that when someone is exposed in utero or early life to stressor, that can cause a change in the gut microbiota. In other words, microbiota changes can be a consequence of being exposed to stress. And stress early in life, we know, is a significant risk factor for many mental and medical disorders. The other line of research relevant to this question is, how does it do it? How does the change in the biota lead to disease states? And one avenue is through a hyperactive HPA axis. And as a consequence of having an exaggerated stress response or stress neuroendocrine axis, the person's at elevated risk of not only depression and cognitive impairment and anxiety, but also at elevated risk of obesity and diabetes. Another question is what specifically defines a negative in utero early life experience? That's a great question. We now know, based on many lines of literature, that when the fetus is exposed to malnutrition, that is a stressor. When the fetus is exposed to cigarette smoke, that's a stressor. And when the fetus is exposed to a bad diet, or for that matter, infectious agents, these are all stressors. And that is an environment that promotes changes in the gut microbiota. I've not been exhaustive in my list of potential negative experiences that could alter the gut biota, leaving that offspring at higher risk of both mental and medical disorders. The question comes in with respect to modification of grains. Are genetically modified grains responsible for chronic inflammation? I cannot say with certainty, because I don't know about genetically modified grains and what role they would play in inflammation. That's something I don't know. But what we would say is the following: is we do know that when our diet is comprised largely of refined foods, comprised of saturated fats, certainly lacking the diversity of nutrient, that is associated with a decrease in microbial diversity. Said simply, there is a reason why individuals who, for example, have Mediterranean diets are less prone to depression than people who have a more Western or refined diet. But whether genetic modification of the grain is involved, I really can't really say at this point. Another question is, should infants born through cesarean section or bottle fed be supplemented with pre or probiotics? What an excellent question. I think just to put a bit of a background to that, we do know that the first point of contact for the infant, that is exposure to the microbiota, is during vaginal delivery and or through breastfeeding. So if the infant is not exposed to breastfeeding or is delivered through cesarean section, does that mean that this offspring will not have an opportunity to be exposed to biota? And the answer is no. Eventually there will be exposure. Our environment is replete with viruses and bacteria, and eventually the newborn will of course transition over to foods and is exposed to really a plethora of different organisms. So eventually we'll catch up. But I don't want to make it sound as though they catch up and then everything's fine after that. We do have to also live with the literature that does tell us that a group of offspring who are born through cesarean section and or through they don't have a vaginal delivery, they seem to be at a higher risk of some immune-based disorders like type 1 diabetes, maybe celiac disease, things of that nature. And so there is this view that perhaps in fact that risk was imparted by effects on the microbiota, the microbiome. Another question here is, please expound on the concept of fecal transplants in humans. Given what we now know, that there are some disease states that are linked to dysbiosis, the best known is Clostridium difficile infection seen in hospitals, which can be actually fatal, but many other disorders ranging from neurologic, cardiovascular, metabolic, psychiatry, and others. Is there a role for fecal transplantation? Certainly for C. difficile, one of the treatments that's been shown to be very effective is fecal transplantation. At this point, we cannot say that fecal transplantation would be a viable or proven treatment for other medical conditions, but there's over 100 studies going on currently in the U.S. and around the world looking at this very question, ranging from depression to bipolar, obesity, many others, whether fecal transplantation could in fact help these individuals. And certainly this is something we're going to be hearing a lot more about. But for now, no, we cannot say that these individuals should be receiving fecal transplantation. Next question is there any interaction between brain stimulation, for example, with electroconvulsive therapy or transcranial magnetic stimulation, and inflammation? Absolutely. This is really, really interesting, especially with ECT. This has been looked at where investigators have looked at key intermediates or key species involved in inflammation, such as kynurenine or kynurenine-tryptophan ratios. And really to keep this, I think, digestible, what I would say is we are now seeing biochemical evidence that ECT is anti-inflammatory, which is really, really interesting. And this is what I would say is a nexus, because mindfulness-based psychotherapy, sleep, hygiene, good antidepressant therapy, they all seem to be anti-inflammatory, and of course so is exercise. So we think that anti-inflammation may be a convergent point across disparate treatments for depression, including neurostimulation. One of the questions is, if one tries to support a healthy and diverse gut from a dietary context, are probiotics a viable option, or would prebiotics be more effective? There's two parts to that question regarding two different treatments, and we should not assume that prebiotics and probiotics are the same. And just for clarity on the glossary, probiotics is the provision of actual organisms, the bacteria, for example. And a great example is what you would take in yogurt as just one illustration. Prebiotics is the provision usually of food that promotes the growth of microbiota. Good examples like something like cabbage or starch or things of that nature. The second point is when we're talking about prevention or treatment, at this point in time, what I presented here today at the conference is we just don't have sufficient rigor to the science right now to say that supplementation with pre or probiotics is sufficient to prevent mental illness, nor do we have, I think, unequivocal evidence that it's actually highly effective as a treatment for an established mental illness like depression or bipolar disorder. What's there, however, gives us a reason to believe that probiotics may in fact have some antidepressant properties, but I want to emphasize the studies need to be enhanced with a bit more rigor. I also mentioned during the conference today that the antibiotic minocycline, interestingly enough, does have some evidence that it could actually treat depression. And I have used minocycline, and I've done research with minocycline showing that it is antidepressant in people with major depression or bipolar disorder. So for now, I do not think we're in a position to make a strong recommendation or certainly call out a certain type of brand of pre or probiotic as it relates to preventing or treating mental illness, but we certainly have enough research now to really conduct a very large randomized placebo-controlled trial. We desperately need it. Next question is, can I speak to the validity of using low-dose naltrexone to treat autoimmune or inflammatory conditions? I think at this point in time, when it comes to treating autoimmune or inflammatory conditions, I wouldn't see naltrexone at this point as being a treatment that would be high in the algorithm. There are obviously a host of first and second line treatments, and for depending, of course, which condition we're treating. Then we move into DMARDs, disease modifying type treatments, and then we have the monoclonal antibodies and so on. I see those types of treatments as the most evidence based. There's no question that inflammation and the opioidergic system are in crosstalk with each other, and the idea about mitigating inflammation through opioidergic pathways has really been a concept around for a long, long time. But at this point, I don't actually see myself treating inflammatory conditions primarily with a treatment like naltrexone. Next question is, since I educate my patients on low carbs when they lose weight on olanzapine and they improve on many other aspects, as much as 20 pounds, do I think it has something to do with the microbiota? I do. I really believe that psychotropic drugs like olanzapine that cause a lot of weight gain perhaps could be causing that weight gain via alterations in the enterotype. That's a very reasonable and now empirically supported hypothesis. Secondly, gut manipulation through diet, like reducing carbs, causing weight loss with olanzapine, is quite possibly doing it in part by its effect on maybe enhancing the richness and the diversity of the gut microbiota. I absolutely think that's the case, and something we've really got to look at. One of the interesting questions, which we don't know the answer to, is that some of the established weight loss FDA medicines, like the combination of naltrexone bupropion or incretins like liraglutide, we don't know for sure whether these drugs are actually reducing weight through the gut microbiota, but that is obviously another pathway we need to pursue. Okay, another question here is, what are my thoughts on a elevated white blood count found in a routine CBC in inpatient presentations? I think that it's common for many clinicians to see an increase in white count in some patients. I think what the question is getting at is, do I think there's a subclinical infectious exposure perhaps explaining this? And to be quite frank, I don't know if I know the answer to that. We know that many medications in psychiatry can increase white count, like lithium, so I'd always be wondering about that. And there's also other factors that could alter the white count just simply by, maybe being exposed to stress and things of that nature. So there's a number of factors that could be at play there, but I think if I'm getting the question right, is that indirect evidence of subclinical infectious exposure? And right at this point, I'd have to say I'm just not sure about that one. Very interesting question, though, indeed. Can I comment on the effect of fasting, specifically the fasting that involves no food or water for 17 hours on gut and mental illness in general? Well, this is an interesting area. We know that caloric restriction can be beneficial to general and mental health. It's quite possible that fasting could be a bona fide treatment for a mental disorder. I wouldn't recommend it just yet. I don't think we're there yet. I'd also say the same thing for a ketogenic diet. I think we still do not know whether that's established as being a viable treatment for major depression or bipolar or schizophrenia, for example. Certainly it's a very promising avenue, but we don't know yet. The effect on the microbiota, great question. I don't think we know whether fasting itself is really the route wherein some of these fasting some of these fasting diets can really, in fact, improve mental illness, or for that matter, improve well-being. Is it going through the gut? We do have literature to show that, yes, abstaining from food does, in fact, have effects on the microbiota, but are these so-called abstinence diets, are they, in fact, changing the microbiota, and that is what's mediating the health outcome? Not sure, but a very good question. So we've got another question here about chocolate, and could I say more about how chocolate decreases inflammation, and how much chocolate do I have to eat on a daily basis? Well, this is a fun question because I think many of us like chocolate, and nothing sounds better than being told that some of your vices are good for you. Well, look, there is an interesting literature. It's been around for a little while now that has reported, especially dark chocolate, having some alleged health benefits, maybe on cardiovascular well-being, maybe on mental health outcomes, for example. And quite frankly, the theory that's been put forward is that there is maybe perhaps some antioxidant based on some of the chemicals that are in dark chocolate, and maybe also some anti-inflammatory aspects. I would say for now that we would not recommend dark chocolate for patients as a treatment for a mental illness or their symptoms. That literature is very interesting. I think we have to accept there are aspects in dark chocolate and milk chocolate that are not so healthy, like high glucose content. So I think for now, for me, when I hear about how dark chocolate has potential health benefits, for me, I don't interpret that as this is the call for me to go to the local store and get my favorite 70% dark chocolate. For me, what that is really for me to get into the laboratory and say, what is it in the dark chocolate that's actually doing this? And is there something that we can pull out? There's a lot of interest in the antioxidant, anti-inflammatory components in dark chocolate. I love dark chocolate, but I'd have to say I still don't feel we're at a stage where we could recommend that patients should be, taking a couple of squares of dark chocolate a day to help their overall health. I want to thank you all for participating in this session. I've really enjoyed these questions, and I think you would have to agree with me. Like any good topic, a good topic is best illustrated when there's more questions than there are answers, and this one is a great one, I think, that illustrates that. So thanks so much for participating.
Thanks for listening. Stay tuned for the next extended Q&A sessions from NEI Congress 2019, and make sure to subscribe.